Hello everyone. Good afternoon. Just checking the audio. Kindly confirm if you are able to hear us clearly. Okay. Hello everybody. Good afternoon. Good evening. I'm Dr. Aditya Agnihotri, Secretary of KCIAPM. I welcome you all to the season 2 of KCIAPM PathWebinar that we initiated during the COVID times. I hope that you all will all continue to encourage us and by joining us live for all the sessions every second Saturday at 6:30 p.m. with wherein we will come live with our experts on relevant topics. And today we have a very important guest with us who will be delivering a renal path topic for us and will be teaching us on that topic. And before we get started with that, I have a few instructions for the audience. Please leave all your comments in the chat box so that we will take all the questions at the end. Please set your YouTube resolution at 720 pixels or the highest possible quality so that you can have a very clear video. And before we get started, I'll now hand over the session to Dr. Archana Bhatt, who is a member of our social media subcommittee, to introduce our faculty. Over to you, Dr. Archana Bhatt.
Thank you, Dr. Aditya. It's indeed my proud privilege to introduce to you all my mentor, my teacher, Dr. Mahesha Vankalakunti. Sir has done his MD from the prestigious PGI Institute, following which Sir has done 1 year PDCC in renal and transplant pathology at PGI. Sir has also done 1 year fellowship in medical renal and transplant diseases and urologic pathology at Cedars-Sinai Medical Center, Los Angeles, USA. Sir has also done 1 year clinical nephropathology certificate course by the International Society of Nephrology. Sir's the fields of expertise are anatomic pathology, nephropathology and renal transplant pathology, urologic oncopathology. His achievements include establishment of Referral Center of Excellence in Nephro and Renal Transplant Pathology at Manipal Hospital, Bangalore. Sir has experience of interpreting medical renal and allograft biopsies of about 46,000. Sir's Guide for Nephropathology Fellowship course. Sir has authored over 50 publications in various national and international peer-reviewed journals. Sir has co-authored chapters in books titled Diagnostic Pathology Genitourinary, ABO Incompatible Kidney Transplantation. Sir is a reviewer board member in pathology and nephrology journals. Sir is executive member of the Indian Society of Renal and Transplant Pathology Society. Sir is a member of national societies like KCIAPM, IAPM, IAPID, and ISRTP. With this brief introduction, one more thing I would like to say is Sir is a well-known name not only in the pathology community but also in the nephrology community. And there are so many biopsies not only from India but even from other countries which are referred for Sir, owing to his expertise in this field of nephropathology. With this brief introduction, I request Mahesh Sir to take over and present to us today's topic.
Thank
Over
you.
to you, sir.
Thank you, everybody, Dr. Aditya, Dr. Archana, and all the audience. So I'll share my presentation here. It's been a experience to share the PPT here with the KCIAPM for the second time. The first was in the beginning of this COVID. Is everybody can see the PPT?
Perfect, sir. Please go ahead. Thank you.
Sir. Yes, sir.
Okay, thanks. So the title which I have kept is a recipe for complete nephropathology. I mean, just to about the way how I titled it is just as keeping in mind about the postgraduates who are in the final year and who wish to learn nephropath or even the residents in nephrology who wants to have the experience of the first-hand experience of what goes in and out in the nephropathology lab and what is expected from them. So that's why I put it as recipe so that the ingredients, all the ingredients that is necessary should be known to all of them. And the content of this next 1 hour is only for these and not for the experts, because they all know about these things. So we'll begin with a couple of illustrative cases and then build on the story on the requirements for nephropath career. The first case is about a 9-year male boy who presented with anasarca and nephrotic range proteinuria. The first presentation was at the age of 2, and now he has come with the relapse of nephrotic range proteinuria, and the urine routine analysis showed inactive sediments, and the normal renal function was normal. And he had other abnormalities like hypoalbuminemia and hypercholesterolemia, so that it can be labeled as nephrotic syndrome. One of the peculiar history in this case was that his brother also had a history of renal disease at the onset of 6 years. The histology in this case, since it was a relapse, they wanted to know that there is any podocytopathy, and if there is any appearance of FSGS, because in the first decade, the indication for renal biopsy in a nephrotic syndrome is only if there are any atypical features. And in this case, there was a family history, so they wanted to probe more into the histologic aspect of glomerular pathology. So in this biopsy, as you see on the top, the scanner view, there were 60 glomeruli, and on the higher magnification, all of these gloms, which are seen in different stains, will come to the staining stains later on. The first being the PAS, the meson trichome in the middle, and the silver stain on the right hand side. They all display the features of a normal glomerular morphology, in the sense like the capillary walls are normal, there's no thickening of it, or there's no double contoured appearance, and there is no hypercellularity in any of the compartment, I mean the subsegments of the glomerular tuft, meaning in the mesangial region or in the capillary lumen, there is no proliferation as such. And in the immunofluorescence, as you see that there is no lighting up of any of the immunoglobulins or the complements in the glomerular compartments. So the immunofluorescence is negative. In the electron microscopy of this patient, which is on the left-hand side, shows that the podocyte foot process are effaced almost all of the circumference of the capillary wall on the outer side. Normally, it should show this appearance of fence-like appearance with the slit diaphragms, whereas in this abnormality, there is complete effacement of the podocyte foot processes. And this finding would arrive at a diagnosis of minimal change nephrotic syndrome or the minimal change disease. The next patient is a 27-year-old lady who is a known case of SLE on treatment with hydroxyquinone and steroids. She had hypertension and has presented with new onset, the first presentation in a SLE patient with renal abnormalities of 3+ proteinuria, and the complements being low, with autoimmune serologies being positive for ANA and dsDNA. The ANCA, other vasculitic parameters, and the viral markers are negative. She also has the systemic symptoms in terms of joint pains and alopecia. And in the hemogram, she has anemia and platelets are low. There is a raise of LDH, and the biopsy was performed, and in this, almost all the gloms had a similar feature of hypercellularity within the capillary lumen, encroaching upon the capillary lumen so that there is no space visible in the capillary lumen. And the feeding arteriole or the preglomerular arteriole shows intimal hyaline deposits. And here on your right hand side, you can see that the fibrinophilic deposits are seen in mesangial region as well as in the capillary walls and even in the capillary lumen, so that these are called as hyaline globules. And one can also appreciate that there is a double contoured appearance of this capillary walls here. In a few of the gloms, there was a global distribution of mesangial resolution or the dissolution. Thereby, we attribute this kind of a finding for a mesangiolysis, where the normal mesangial structure is completely destroyed in the glomerular compartment, and there is a near total occlusion by the fibrin within the feeding preglomerular arteriole. So there are vascular lesions, and even here you can see that there is complete occlusion. So there is a vascular lesion in addition to being a proliferative, diffuse proliferative glomerulonephritis in a case of SLE. The immunofluorescence has the full house effect, as you can see here. With the antisera of IgG, the capillary walls, the mesangium is studded with these granular deposits, and so as with the C3 complement and the C1q complement in the glomerular areas. Even in the vessels, the IgG is lighting up in the intimal aspects and the transmural aspect of this arteriole in a granular pattern. So the same finding in the other vessels and the tubular basin membranes. Here, in this case, the granular pattern of deposits along the tubular basin membrane. So in this case, it was more of a class 4 diffuse proliferative glomerulonephritis, which is quite active without any chronicity feature. Along with that, there is addition of vascular lesions in terms of thrombotic microangiopathy, which is immune mediated. Moving on to the case 3, this patient presented with nephrotic range proteinuria of 10 grams per day with a hypotension and a renal dysfunction with a creat of 5.1. The ultrasound examination had normal size kidneys. He didn't have any other systemic symptoms. So looking at the renal histology in an elderly, I mean not elderly, but in a middle-aged man, this score unfortunately went quite deep, and it was more of a medulla, and little bit of cortex is being sampled here, which on a higher magnification shows that there is some eosinophilic material which is encircling all these tubules, but there is no glomeruli, although he had 10 grams of proteinuria. With this finding, one can assume that the same abnormality would have been there in the glomerular compartment. So in dissecting the nature of these deposits, the congruent stain would be very helpful, and which clinches the diagnosis in this case, as here it's at the deeper medulla. You can see the urothelial lining here at one end of the core, and the amyloid deposits being congophilic. And in the immunofluorescence, there was no renal tissue. It was more of a soft tissue which was being sampled in the adjacent area, and we did the immunofluorescence by enzyme digestion which showed no restriction of the lambda or the kappa light chains. So this is the birefringence, which you see under the polarizer microscope, which gives apple green birefringence. And since there is no restriction, we went ahead and did the immunohistochemistry for serum amyloid A protein, which was brightly positive, and hence labeled this as a amyloidosis of AA type. So the case 4, again, a 58-year-old male who had presented with anemia and proteinuria of 2+ unexplained renal failure, and the complements and the serologies were all negative, with the increased echoes on the ultrasound examination. So even in this case, the Gloms were not sampled. The abnormality which is seen here, although it is very much diagnostic of the lesion, as you see here at the scanner view, the tubular lumen shows casts which are filled in the filling up in most of these tubules. And on higher magnification, you can even make out that the outer border of these casts are taking the shape of the luminal contours, and at some places these are appearing as fractured, eliciting the reaction of epithelial cells, as you can see here at the bottom, the epithelial cell reaction to these casts. Yeah, and these casts on the PA stain appear as very light stain, in contrast to that of the basal membranes of these tubules, or even the Bowman's capsule if it is seen in the adjacent area. So as you see here in the trichrome, these fusionophilic are the ones which are monoclonal, and the bluish appearing are those which are hyaline casts, which can be mixed with this monoclonal to give a kind of cushioning effect in the tubular lumen. In the immunofluorescence, these casts were restricted in terms of only being positive with the lambda, and the kappa was absolutely negative. So thereby diagnosis of a light chain cast nephropathy of lambda light chain restriction was made, and further workup was done in this patient to see what is the bone marrow and the free light chain assays, the serum immunofixation, and the protein electrophoresis. So that's how the flowchart of this diagnostic lesion would carry forward. The case 5 is about a 54-year female who had a chronic kidney disease detected almost a year ago with a creat of 2, and now it has inched up to 7.9 with the symptoms of azotemia. And the urine routine did not show much of protein leak, and neither clinically she was seen to be edematous. Ultrasound abdomen showed that the kidney size was 9 cm on both the sides with increased echogenicity. So by virtue of very less amount of protein and not having clinical edema, this rules out that the disease is primarily of tubulointerstitial and not glomerular origin. The biopsy was done in this in the histology of the H&E stain. One can see that these tubules are packed with these crystals which are arranged somewhat radially, and the color of which is a brownish in nature. So these kind of crystals are seen in inherited diseases. We'll go in the next slide, which inherited disease shows this kind of crystals. Under polarizer microscope, these are birefringent. These needle-shaped crystals are birefringent, and on the silver stain, they appear as blackish. They take up the stain with the silver stain, and that's how appear as jet black. The trichrome doesn't take much of stain in these crystals. So the morphology of these crystals was very much consistent with 2,8-dihydroxyadenine crystals, and the further workup for urine levels of 2,8-DHA and the enzyme activity of APRT, following which the genetic testing, if available, should be performed so that the diagnosis is made based on these results. And the kidney histology, the histology is more of a compatible diagnosis with the APRT deficiency. In the genetic analysis of this patient showed that there was a pathogenic variant of APRT, which was homozygous in this, and thus confirmed that this is indeed APRT gene defect causing the crystals, which is an autosomal recessive enzyme defect of the purine metabolism, thus leads to deposition of these crystals forming nephrolithiasis. So the salient features of all these cases, in the case number 1, it was more for a diagnosis in a relapse of nephrotic range proteinuria, nephrotic syndrome, and with a history of family, one of the family member being affected by kidney disease. So in such cases, the genetic study also should be considered to see if there is any mutation in the WT1 or a PFLC gene because of the age factor in that patient. It was almost 9 years. So depending on the age and the onset of symptoms, the mutations can be varied, and that's how the diagnosis can be made. And the prognosis also depends of the family history. If they go on to ASKD and they get transplant done, the prognosis is of recurrence of the disease is different from those who have FSGS or other forms of podocytopathy, which leads to ASKD. In case 2, it was more for a class identification of SLE and to prognosticate, because the vascular lesions, if they are found, they tend to portend like a very aggressive histology, aggressive behavior of the disease. And in case 3 and 4, although the gloms were not there, and just based on the glomeruli, if we say that the tissue is inadequate, it will be bad on our part. It's just like in cricket, like a bowler overstepping the line, but still the batsman can hit a 6. So you have a scope for looking up any diagnosis which comes out of the tissue. So in the case 5, it is more for the yield of the histologic finding, which can further ask for testing either in terms of genetics or any other clinical clue that you would like to, or any other serology test that you would ask for to the clinician. So that's how the renal histology helps in the diagnosis, the prognostication, and the aggressive nature of disease, or the chronic nature of the disease if the patient has presented a little late, and also in exploring the diagnosis in other various modalities. So coming to the modalities, before the modalities, like what do we have to get the information, because we don't see the patient like face to face. The clinicians are the ones who does the biopsy and they give it to us. The clinicians, when they give the information, these are the things that we need to gather, like the age and the gender, because there are certain kidney diseases which are limited to certain group of age, and gender, especially with the SLE, it's more with the females than the males, so that and history of diabetic or the hypertension as a comorbidities, and the symptomatology pertaining to the renal system in terms of duration of all the features like edema or the azotemia. How long has it been? Is it a recent onset or is it a progressive increase in the edema? So even this helps in certain cases of diabetic patients when there is a new onset of edema, where it is due to diabetes or existing coexisting podocytopathy causing the symptoms. In the next would be the systemic symptoms in rashes or the oral ulcers, arthralgia, alopecia, hemoptysis, the ear symptoms, or the eye ophthalmologic symptoms, scleritis. It's more of a rheumatologic kind of thing in looking at the systemic symptoms. The lab parameters, it would include the complete hemogram and the peripheral smear to look for if there is any evidence of microangiopathic hemolytic anemia, or is it the anemia of a chronic kidney disease, and also the retic count, LDH, and so on in the hemogram. Coming to the urine routine analysis, the various aspects of looking at the active sediments, the proteinuria, and the it's a big ocean. The urine is considered as the window for the kidney to look for easily detectable abnormalities. In the blood, the autoimmune and the vasculitic serologies and viral markers, and in elderly, especially in patients who have unexplained renal failure, the protein electrophoresis and the free light chain assay needs to be considered in the radiologic examination to look for what is the size of the kidneys and how does the interstitium appear on the sonogram, whether there is increased echoes or any other finding in the ultrasound. So based on all these clinical details, the clinician would put it in a syndromic approach, whether it is a nephrotic syndrome or a nephritic syndrome, or is it just an asymptomatic presentation of hematuria or the proteinuria, or the progression of renal failure, whether it is rapidly progressive or is it a sudden onset acute kidney injury, or if the kidney disease has been there for a quite long time, then a chronic kidney disease would be named as a syndromic presentation. So these syndromes have to be just like the nephrologist, or we also need to put a syndromic way of presentation in each of the biopsies, so that our eyes is tuned to see what the clinician or the patient has presented with. And the kidney, as everybody knows, that the kind of injury that is seen, the same presentation or the morphology can be seen in various diseases and the vice versa. Like here, if you see on the left hand side, the syndromes and the pattern of glomerular injury on the right hand side, which is color coded. Like say, for example, if you're looking at a middle-aged man with the nephrotic syndrome, then you would keep the differential as a minimal change disease or a FSGS or a membranous nephropathy. So that's how we have to keep the differentials based on the syndromes. So the urine analysis, which is very critical in looking at what's the kind of abnormality in the kidney, and that is reflected in the urine, which is it could be of a cast, as you see here, or the crystals, whether it is a uric acid crystals, monohydrate or a dihydrate, or even if the RBCs, if they are present, whether there is any dysmorphic RBCs or the acanthocytes, and so on and so forth. So, a detailed urine analysis is done, and most of the nephrology centers, they have a site lab and they do urine routine then and there, so that it becomes easy for them to further manage. Like this table illustrates the various kinds of casts that are seen and the clinical associates. Like say, for example, if the urine shows more of neutrophils, then it's more likely to be a pyelonephritis. And if it is more of a fatty, the globules, then it suggests some kind of a podocyte damage with nephrotic range kind of a proteinuria. So one can see this table and fine tune what is the expected finding in the renal histology or the clinical behavior of the symptomatology. So urine routine and then the complements and the vasculitic markers. In the complement pathway, what we usually do the testing is to look for the C3C in the serum and the C4, whether there is any activation of one of these pathways, like the classical pathway or the alternate pathway, which leads to consumption of these complements, and they tend to be on the lower side if there is a activation of the cascade. And there are different types of GN per se, or limited to the primary renal disease, or even in systemic renal disease, which activates the complement and leads to activation of the individual pathways. So on the right hand side, you have the list of which pathway is affected, and on the left hand side, the disease associated with it. So moving on to the anchor serology, which is very important when it comes to evaluation of a patient who has a rapidly deteriorated renal function. There's no value of anchor serology being done if the patient is a nephrotic in a nephrotic setting, but it has more value when it is done in patients who have RPGN or the RPRF presentation. So the among the two modalities to test for these ANCA, the ELISA is recommended, which is highly specific than the indirect immunofluorescence. The predictive value of pauciimmune crescentic GN, this table highlights that the presentation of RPGN in a patient who has a pre-test likelihood of almost 50% being in the ANCA serology, and in a post-test likelihood of this turning out to the crescentic is almost 95%. So depending on the various levels of the renal deterioration, like serum creatinine of more than 3 or 1.5 to 3 or less than 1.5, the likelihood goes down in percentage with the presentation of crescentic GN. So these were the clinical details which more or less covers the various aspects of the syndromes to pinpoint in which syndrome does the patient fit in. After the biopsy is done, what are the modalities that we have to look for in the renal pathology assessment? One is the light microscopy, the second one is direct immunofluorescence, and the third one is the electron microscopy. So in the light microscopy, the tissue, as any other surgical pathology, the tissue is processed in the same way like as any other surgically excised tissues. The only difference in the nephropath cutting is that they have to be very thin, almost in 3 micrometer in thickness of the tissue cutting, whereas in the routine surgical, they deploy 5 micron thickness. And unlike in surgical path, we have to cut multiple step serial levels. We go up to almost 32 to 40 in our lab. The recommended is that of more than 26 step serials should be cut in evaluation of any of the renal histology, because some of the lesions are very focal and you tend to miss out if the number of step serials are less. The usual stains, what we see, what we do is the pyritic acid Schiff and the pyritic acid methenamine silver, which is otherwise called as Jones, and the Meson trichrome. The congruent is done in a specific subset of patients. The other stains that sometimes we do ask for is the Prussian blue and the oil red O. For us, the special stain is hematoxylin and eosin, unlike the surgical pathology. And the hierarchy to be followed is the glomeruli, the tubules, the interstitium, and the arteries. So this is how the flowchart of individual assessment to be done. The staining, which I was referring earlier, this table shows that the different structures of the glomerular compartment, be it a mesangial region or the capillary wall or the Bowman's capsule or the nuclei of the tubules or the nuclei of endothelial and the mesangium, what are the colors that can be seen in different stains. So here is a pictorial picture on the right hand side, and you can see various structures and what are the colors that are displayed in this table. So this has to be in and out because nephropathology or whosoever is practicing renal path, they literally play with these three colors, these three stains. So they have to be well versed with the colors that are seen in the histology. So in the first case, which I showed you, that the patient, the 9-year-old kid, in the biopsy, there were almost 60 gloms. So 60 gloms is more than enough. To say that the tissue core biopsy is adequate, we need to have some set of gloms so that there is no lesion being missed out because of the sampling error. And also the abnormality in some of the diseases appear in the juxta medullary region, the glomeruli which are located in the juxtaglomerular region. Say, for example, FSGS appears in the juxtamedullary cortex. So this table highlights that the probability of missing a focal lesions like FSGS goes up to 35% if the number of gloms in the given core is only just 10. And if it's doubled, like 20 gloms are there in a given biopsy, then the chance of missing out decreases to 12%. So 25 gloms, the percentage of missing out lesion comes down to 5%. Although the clinicians would make fun out of the of the pathologist, saying that no matter how many gloms we give, there is always a possibility of missing out the lesion on the lighter side. And in the assessment of renal histology, the glossary of terms, various terminologies. You can go through this in the subsequent later. But the mesangial hypercellularity, what do you mean by a cellular crescent, or the nature of the crescent, if it is just an active or a fibrous element is already being set in, or it is predominantly fibrous crescent? And what is the definition of an endocapillary hypercellularity? All this various terminologies are there with the each of this being diagnostic of or the hallmark of individual disease process when it is clubbed with the immunofluorescence. And say for that example, like nodules in the glomeruli. So what are the differential diagnosis of a nodular lesion in the gloms, like here? So it could be a diabetic, if the patient is diabetic, with a retinopathic changes, plus or minus retinopathic changes, or is it a MPGN kind of a pattern where the double contours are also there in addition to nodules? Or is it just a acellular deposition of material in the glomerular forming nodules in case of amyloidosis, or in the plasma cell dyscrasia where the pattern of injury is in the gloms forming a uniform nodular expansion of this deposit disease. So you'll have to come through the differential diagnosis of one particular abnormality and build on the list of diseases that can be seen at the light microscopy level. So you get the aid of immunofluorescence, and then further you narrow down the differentials, and along with the electron microscopy in some of the cases like in MIDD, it is very clear cut. Although in amyloidosis, you don't need electron microscopy on a case-to-case basis, but in early cases of amyloid deposition, you may need the help of ultrastructure level. So these are the special stains and the immunofluorescence and other viral serologies which can help in dissecting the nature of nodular pattern. So at the light microscopy level, we have to address what are the active features present on the renal histology, whether it is in terms of proliferative capacity of the endothelial cells or a hypercellularity in the mesangium, or is it an extraneous presence of neutrophils, which is obscuring the glomerular capillary lumen, or is there a tough necrosis, which is very brisk and active of a recent onset? That means that the the tissue destruction is quite active, so that the immunosuppression can be given. The crescents and the aging of crescents, whether there is any interstitial edema, which can be brought down by steroids, and if there is any active inflammation, like as I said, the neutrophils presence in the glomerular capillary lumen, which can be treatable. And on the right hand side, it's more of a chronic lesions which are partly irreversible, and when these predominant over the active lesions, then the chance of recovery goes down, irrespective of what kind of immunosuppression being administered. So the extracapillary hypercellularity, as you see here, the Bowman space is being occupied by the cellularity. This is one of the critical alert that we need to address to the clinicians at the upfront, because this helps in the management very acutely. And some of these patients may even have hemoptysis, which is kind of a life-threatening. And we have to, at our histology level, we need to differentiate whether this is a true crescent or a pseudo crescent. So we'll come to this in the next lecture. What do you mean by true or a pseudo crescent? But anything which is occupying the Bowman space is extra hypercellularity, which should be alerted at the upfront. This slide highlights about the guidelines that have been recommended to be for the light microscopic description, or what kind of a pattern of injury is there in the glomerular compartment, and all the individual abnormalities. What is the percentage of the gloms being affected by crescents or hypercellularity in the endothelial cells, or is it exudative? So all the aspects need to be quantified and given addressed in the histology report. Moving on to the second modality, that's immunofluorescence. The routinely done immunofluorescence is that of immunoglobulins, which comprise of IgG A, G, A, and M, and the complement C3, C, and C1q. And the light chains like kappa and lambda. Very rarely one can also do the fibronectin if available. And the pattern of deposits can be granular or a linear, and negative or a posse. Posse, the word is used because of the intensity, which is being less than 2 on a scale of 0 to 4. And the positivity, we need to see that the deposits are lying in the mesangium or a capillary wall, or is it even being present in the lumen. Not just in the glomerular compartment, but also in the Bowman's capsule and extra glomerular area like tubular basin membrane and vessels. The intensity, as I said, it's to be scored between 0 to 4. Some even score it as 0 to 3. It is subjective, and they have to address in their report what is the scale that they are following. Anything above 2 is considered as positive. These are some of the illustrations where the IgG is negative in the gloms, and here again these encircled ones are the negative glomeruli. You can see that there is internal control. The protein droplets within the tubular cytoplasm take up this stain. In case of membranous glomerular nephropathy, the granular deposits are more or less uniform along the capillary walls. Vis-a-vis, they are irregular and they are not uniform. They are coarse deposits in case of infection recit associated glomerular nephritis. In the IgA nephropathy, the deposits are more or less seen in the mesangium, which are packed here of almost 3+ to 4+ in intensity, and very rarely they are seen along the capillary walls. So some of the experts also feel that the capillary wall deposits in a case of IgA nephropathy is a poor prognostic sign. And if all the immunoglobulins and the complements, including C1q, is positive in the glomeruli or even in the extraglomerular lesion, then the case is assigned as a full house pattern. More or less, it indicates that it is a systemic disease which is affecting the renal tissue, and workup for autoimmune disease needs to be done. These were all the granular deposits. And what about the linear? So the linear deposits along the capillary wall here, they're basically the IgG, which is highlighting the capillary wall, and thus is diagnostic of a anti-GBM glomerular nephritis, which if the patient has pulmonary symptoms, then it is called as a good pasture syndrome. These were about the immunoglobulins and the complements and the pattern of deposits, whether it is granular or the linear. Coming to the light chains. So whenever any of the disease which is mediated by immune complex, they are polyclonal, thereby meaning that kappa and lambda all would highlight the same area in both the with both the antisera, although the intensity might vary in a log difference of 1. But in case of IgA, the lambda is more dominant than the kappa. One should not straight away jump in and call it as a light chain restriction of lambda in a case of IgA nephropathy. Coming to the other diseases of monoclonality, be it cryoglobulin, monoclonal cryoglobulin GN, where the kappa and lambda would show restriction of one of the two, or be it a light chain cast nephropathy. So the kappa and lambda in the immunofluorescence would serve a quick diagnostic clue if we miss out the kappa and lambda in our panel, then it would lead to an erroneous diagnosis of just tubulointerstitial nephritis, which may be mismanaged and will lose out the time, crucial time, and these patients will end up having interstitial fibrosis, which may be irreversible. And in case of amyloidosis, one of the light chain, if it is plasma cell dyscrasia associated amyloidosis, one can have one of the light chain being restricted. As you see here, it's more of a lambda chain restriction and negative with the kappa. The presence of extraglomerular deposits, as we saw in the one of the case history, it straight away gives the impression that this is not a primary renal disease. It's a systemic disease which is affecting the kidney. And with this finding, we ask for autoimmune serology, because that's the prototype, the SLE being the prototype, which has positivity with the extraglomerular compartment. So the guidelines of reporting the immunofluorescence, the description that how we should follow in the immunofluorescence reporting. The third modality is about the electron microscopy. It's just it could be transmission or the scanning, which is 3-dimensional. The transmission is just a 2-dimensional, the upper end of the light microscopy, where the resolution is increased by almost more than 1,000 times in the trans TEM. So the semithin sections which are cut and stained with toluidine blue to see whether the gloms are there or not. And next would be the cutting of ultra-thin sections and stained with urinal acetate and lead citrate with on a 90 nanometer section thickness of the tissue. The preservative is very important. Otherwise, there would be a lot of induced artifacts if there is any distortion of the fixative. There has been various thoughts as to really do we need electron microscopy in the diagnosis of all the kidney biopsies. There are two schools of thought that because of the highly labor-intensive modality and the cost effectiveness, and the third would be the availability of this electron microscopy to look into the diagnosis. So the scope would be dissected in terms of whether it is really essential for diagnosis or is it just a helpful feature or a confirmatory. There has been various literature which went on to say that it is a clinical luxury rather than a necessity, and to almost that the crucial information gathered from electron microscopy is almost in 1/5 of cases. So this is our Indian data, which was done way back in 2000, early 2000, the first decade. And they have listed out the different diagnosis, and they found that the crucial aspect of this modality is in almost 1/10 of cases. And in other 1/5 of cases, the findings were helpful, although not diagnostic in our group. So just to look at the various EM findings, which are diagnostic, is this osmophilic transformation of the lamina densa of this Bowman's, the capillary wall basin membrane, which is diagnostic of a dense deposit disease. Or if the fibrils are there in the deposit disease, and by virtue of the diameter of these fibrils and the kind of orientation of these fibrils, one can dissect whether it is amyloidosis or a fibrillary or a immunotactoid glomerulonephritis. And if there are any striations, then we assign it as a collagenofibrotic glomerulopathy. The nail patella syndrome is again the collagen abnormality, where there would be striations in this case in the basal membrane. And to dissect the nodular diseases or the deposit diseases which are congruent stain positivity or the negativity. So this chart lists out in which way we have to arrive at a diagnosis, if it is congruent positive and based on the fibrils, or if it is congruent negative and what is the further character of these deposits in the ultrastructure. Some of the illustrations of these diagnostic findings in the electron microscopy, the thin basal membrane disease where the thickness is very much narrowed, and in the Alports the nature of this lamina densa rara and the internal it is completely abnormal, giving a moth-eaten appearance. And if there are any inclusions of the myeloid bodies in the podocytes in the case of Fabry's disease, or if there's any fat droplets which is being accumulated in kind of a LCAT deficiency with the presence of lacunae, and even in allograft biopsies, the score, the food process effacement score, predicts the early development of nephrotic range proteinuria in case of the native kidney disease being that of a podocytopathy. So that's the help of electron microscopy in evaluation of renal histology. So moving on to the prognostication, like what do we how do we prognosticate in a given disease? Say for example, in ANCA associated crescentic glomerular nephritis, we subcategorize that as a sclerotic class or a focal class based on the number of glomeruli having crescents, or is it a crescentic if it is more than 50%, or if none of these, then is it a mixed kind of a class? So these various classes give us an insight into how is the renal recovery going to be there. Like say, for example, if the in any case fits into the focal, then the renal recovery is very good with the immunosuppression that is being followed. Very rarely you can have a biopsy in a case of ANCA, ANCA being positive, and none of the gloms reveals any crescents, of course, in adequate biopsy, and only the telltale signs would be these RBCs in the tubules and in rare instances even in the Bowman space, but there is no epithelial cell proliferation to form a crescent. So this could be a early pickup of the lesion, then even before the devastating the crescent has formed. So that just by lack of crescents, one should not say that there is no crescentic glomerular nephritis. But in such cases, we should always comment that there is evidence of hematuria in a setting of ANCA. So they, based on number of glomeruli, there could be a unsampled glomerular capillary wall disruption. So in the light of clinical setting, we this falls in a focal class of GM, POSIMN GM, and of course you would see in the immunofluorescence if there is any deposits, and if there are no deposits in the POSIMN kind of GN with a focal class. So that gives a very positive aspect on the recovery of renal to the clinician. Say for the other disease like SLE, so the biopsy is not done for the diagnosis in this case. It's only to identify which class the patient belongs to at the present moment. And at the bottom, this picture shows the renal involvement at or before the diagnosis of SLE, or the renal involvement after the diagnosis of SLE. So in the case which I showed, it was almost 5 years duration of SLE and had a first presentation later on. So this gives an overview of how almost 50% of the patients with a SLE end up having renal manifestation at some point of time, and which would require a biopsy based on the proteinuria and the renal function and the complement cascade activation. So the response that they would look for, to call it as a complete response or partial response, based on the follow-up investigations after starting the therapy. And since it is remitting and the disease and again activation of the disease in the renal system, they would monitor with the various serum markers like the complements and the activity markers of autoimmune diseases, along with the protein leak, and to have some kind of a sensitivity and the specificity of each of this, which is displayed in this table. So the repeat biopsies is especially done in case of SLE, and also with the allograft biopsies whenever there is an indication in the graft biopsy, and especially if there is a non-recovery of renal function where the first biopsy is done and we have just identified that there is an acute tubular interstitial, and ignoring the staining character of the any tubular lumen contents. So these would again come back with the non-recovery of renal function, and this is one category where we would be anticipating that have we missed out a diagnosis of CAS nephropathy or apply any form of morphologic form of plasma cell dyscrasia, which is not detected in the earlier instance. So there are various articles on the value of repeat biopsy in the lupus nephritis, the class switch, which can be seen from the first biopsy, and in the repeat biopsy, what is the how many patients turn on from non-proliferative to proliferative, or a proliferative which continue to remain in the proliferative, or a class 5 membranous pattern of lupus nephritis in the first instance, and they go on to show if there is any activity in terms of being associated with the proliferative nature in the subsequent repeat biopsy. In other diseases like ANCA, as well as IgA nephropathy, there is some role of repeat biopsies in the literature, which can be looked up for the adjustment of the immunosuppression or the recovery of the earlier histology. The comment line after the diagnosis from our aspect should be based on what are the findings at the morphology level and the immunofluorescence, whether the capillary wall deposits are also present or not. So say, for example, in the IgA nephropathy, the MEST scoring. So what does M1 mean or S1 mean for a nephrologist to start on whether there is any yield, if there is an immunosuppression being given, what is the chance of recovery? So with that respect, we have to comment on the various parameters like M score, E score, S score, and the T score, so that if there is any greater scoring of T, that means that the reversibility chance is less. And the E score or the crescent, the C score, if present, they may improve with the added immunosuppressive therapy. All of this is the weightage of each of these parameters is only if the number of Gloms are 8 and more than 8, the validity of this scoring system. Otherwise, we can give a descriptive pattern of the scorings, but the weightage of this scoring goes down if the adequacy is not there, just because of the sampling error. The ancillary studies, like what are the things and what is the role of doing all these things, whether they contribute to the diagnosis or the prognosis. So this list gives more enhanced ones, like if there is any elderly patient who has a membranous pattern. In these cases, if there is any masked monotypic immunoglobulin in the direct immunofluorescence, so that we do it on the enzyme digestion to detect the masked monotypic immunoglobulin. And the IgG subclass also throws more light into the diagnostic abilities. The immunohistochemistry or the direct immunofluorescence for various markers as listed here can be done. So all this list, the designation of A is given so that it is definitely going to add to the value of diagnosis or the prognostic implication. The immunohistochemistry for these markers can be of moderate in terms of B contributing to the diagnosis. The C4D in the proliferative is possibly, but not really needed in routine cases. And the value of mass spectrometry in terms of adding value in the management, not at the diagnostic, but the management. There is insufficient data to address how much is the value of mass spectrometry in the management of this patient. So the updates in field. So as the field, what we learned in our post-graduation days is different from what is being right now. We are practicing. This was the paper which had come in 2012, where they titled it as membranous nephropathy. So the point I'm trying to make out in this slide is this is a field of constant evolution. We need to keep the updates of all the diseases. Like there has been new insights into the etiopathogenesis of each of these diseases. Say, for example, the MPGN pattern. Now it's not a diagnosis, it's just a morphologic pattern. And similarly, the membranous nephropathy, it is earlier, as you see here on the right hand side, the hymennephritis as a model. It began with that in 1982, and now one of the experts like Dr. Richard Glassop, he concluded that it's as a result of major breakthroughs, we now find the field of membranous nephropathy to be in a state of disequilibrium, in which the accelerated rate of new information generated greatly exceeds the discard rate of the older information, and the total information has expanded markedly. So coming from the expert, we feel that we need to keep the updates about all these things. And in just a matter of like 9 years or 10 years, it has completely changed the way we look at the membranous nephropathy. It's now dissected whether it is PLA2R associated or a THSD7A associated, and the list goes on. And there are particular diseases which are seen in this group, like say for example, THSD7 is more associated with malignancies, associated MGN, or exhaustin 1 and exhaustin 2. In case of lupus, even they help in severity of the lupus lesions, if it is 1 positive or the 2 positive. SIMA 3B associated is more with the pediatric. So if any of these are found, then we also should attempt to list out the specific diseases associated with it. Next few couple of slides to conclude this. Always, it's for all the surgical fields, surgical pathology. Never feel shy to say that I don't know what this lesion is. So on the left hand side, I can say that it's looking, the shape of this gap is looking like an R. Some might say, looking from a different angle, that this is 7 or a T, or looking from a different angle, it is L. So there are different aspects from various people. So don't feel shy to say or to take an opinion from another person, and which might help drastically in the patient management. So this slide is based on my observation that few things in the amyloid. Usually the amyloid deposits are PS negative and the silver negative. But if you see the positivity with these states, especially with the silver, it is almost that of an AL amyloidosis, unless proven otherwise. And some mathematics in the nephrology practice overall, like if there is a patient who is elderly gentleman or a lady who has presented with nephrotic range proteinuria, and if he or she has hypertension, it's almost the positive predictive value of this turning out to be amyloid is very high up. And if there is any other organ involvement, like say for example liver with a elevated alkaline phosphatase. You don't need a biopsy to diagnose the amyloidosis, but you need biopsy to type the amyloidosis. And one cautionary for the pathologists is to get the congruent stain whenever in patients who are more than 50 with non-proliferative gloms on the histology and who has nephrotic range proteinuria, always get a congruent stain done, especially on the thicker section, so that the early diagnosis of amyloidosis is not missed. So just to have the postgraduates, the residents of fellowship programs, it's always better to have the clinical information, put together the light microscopy findings, and of course the serum and the lab findings with the immunofluorescence, and if available, the electron microscopy, and have a dialogue with the nephrologist or the treating physician, like what are the differential that you would consider, and what is the serologies that has to be done in the further down line in the workup. Like say, for example, the LCAT deficiency, which just presents like a proteinuria and renal dysfunction. But once you see the histology and then you ask, the patient can have a eye manifestation, or even in the liver function tests, which the lipid profile, which gives a diagnostic clue that HDL is very low, and then you ask for the ultrastructure. That thus the diagnosis can be made. Having a proper clinical pathology correlation, the dialogue between the pathologist and the clinician is of utmost importance. So never miss out on calling the nephrologist if you are falling short of clinical information or the lab's information. Just an example for this glom, it's just a normal morphology. It depends on what the diagnosis depends on what this patient has. Is it asymptomatic hematuria where you would work up for thin basement membrane disease, looking up the electron microscopy, or is the patient having a nephrotic syndrome kind of a presentation where you would call this as a minimal change disease? Now there are guidelines on the consensus report on the pathology classification, diagnosis, and reporting of GA, and how we have to report by the experts in this field. This is one paper. And if we address these 5 questions in all the renal biopsies, what is the diagnosis and how active is the lesion? Is there any presence or absence of acute tubular necrosis? How much is the scarring which is seen in the histology? Is it treatable or is it too late to treat? So these 5 questions are the cardinal ones which we should attempt to address, failing which the patient will be having will have to face this brunt of side effects of the over immunosuppression. The list goes on, and it's not just the patient who will suffer, but even the family members, because if the patient is a bread earning member, then gone for toss. The points that we have to address in our report: the primary diagnosis, whether it is an immune complex or an ANCA-mediated GN or an anti-GBM or a monoclonal, and what is the pattern of disease in each of these diagnoses. If there is any scoring or the classification of any disease, like say in the lupus nephritis, the ISN RPS classification, or in the IgA nephropathy, it's Oxford working group classification. So these have to be mentioned, and the additional findings. If there is any ancillary studies required, we always do the IgG subtype and the immunohistochemistry, the enzyme digestion to arrive at a diagnosis. And of course, the chronicity grading is of very much value to the patient for not having, not being over immunosuppressed. My sincere gratitude to all my teachers, starting from second MBBS, where Professor M.H. Kulkarni sir taught us about the renal system. He kind of showed the germs of renal system in me, which in the post-graduation I started learning more from these teachers and the expanded ISRTP family here, which makes renal pathology is very simple if you have all the ingredients to have a perfect recipe for practicing the renal system. With that, in my talk, I am happy to take any questions. So this content was more for having known for the to know the residents how one should have or the practice in each of the organs. So the same system would apply for other organs as well.
Thank you, sir, for that wonderful, elaborate, clear, informative talk. And it was indeed healthy and delicious food. And this complete recipe would definitely have benefited all the attendees. So we have few questions. There's a question by Vrishali Mahajan. Is family history in MCD an indication for genetic testing?
Sorry, come again, I missed out.
Is family history in MCD an indication for genetic testing?
No, it depends on what age the onset of symptoms. Like in minimal change, they generally do not respond well. But if there is any atypical finding, which definitely needs both the histology as well as the genetic counseling, I mean the genetic testing, especially in the first decade.
There's another question by Dr. Manjunath. How essential is electron microscopy with respect to low resource settings?
No, I mean, couple of slides on that, the usefulness of electron microscopy. I mean, this is my gut feeling, like the way how the field is going precision based. But the electron microscopy inputs in all this precision based diagnosis is not to the same level. So in future, the like say, for example, the fibrillary glomerulonephritis, the EM was mandatory in all these cases until recently. There is a immunohistochemistry for DNA JB9 to diagnose it. So by putting that, the EM from mandatory, it slips into the other category as it helps in the diagnosis.
There's another question by Dr. Vrishali Mahajan. How often can we get light chain restriction in IgA nephropathy?
No, as I said, the lambda is more dominant than the kappa in IgA nephropathy, but seeing monoclonality vis-a-vis, you need to have a support of even in the serum as well. Finding a monoclonal IgA nephropathy is very, very rare. I've not seen a case of monoclonal IgA nephropathy till now.
I hope that answers Dr. Vrishali's question. Another question by Barnik. Can one do IF on formalin fixed paraffin sections like we do for IHC?
Yes, definitely we can do, and most of the labs which practice nephropath or they do this enzyme digestion method in the paraffin block. It is not that difficult. The steps that needs to be followed. My mentor, Dr. Ritamra Nada, has a paper on that in Indian Journal of Nephrology. You can find that article to know what are the steps to be followed. Dr. Ashwini is a fantastic, is a magician. He turns everything light up by his magical hands. So you can go through that article.
There's one more question by Jailakshmi PS. Role of PLA2R antibody testing in nephritis.
in nephritis or in glomerular in membranous nephropathy?
He has put it as nephritis here, sir.
Can you
Dr.
reframe that?
Jayalakshmi,
I mean, Dr. Jayalakshmi, can you reframe your question, please?
Dr. Jayalakshmi, if you're there with us, can you reframe your question, please?
For since this PLA2 has come, the indication of biopsy in a middle-aged man who has nephrotic syndrome or a nephrotic range proteinuria, and if the serum PLA2R is present, renal function is normal, then there is no need for doing a renal biopsy. So even the new advances have cut short some of the indications of biopsies, which earlier the renal biopsy was very much mandatory. Only if there is any renal dysfunction, there is a value for doing a renal biopsy to know how much is the chronicity in the case of membranous, who is already proven PLA2R positive in the serum.
That was the last question we had, sir. So thank you so much, sir, for being with us today and for this wonderful talk. Also, attendees, please note, do not forget to join us for the next KCIAPM webinar scheduled for 12th March, which is by Dr. Anita ma'am on CNS lesions. Over to you, Dr. Aditya.
Okay, thank you all. Thank you, sir, for that lecture. I'm sure most of all our residents and nephropathology fellows found it very useful. And all the audience, you may continue to find this video available on our YouTube channel, and you may watch it again if you want. Thank you, sir, for joining us today. And that was
my pleasure.
A good talk. Thanks a lot. Thank you all the audience for joining us today. With that, we'll close the session. Thanks a lot.
Thank you.